respected chairpersons, ladies and gentlemen, let me talk about science. And when I was speaking to last speakers, I was really amazed that how little people know about armed forces medical services. Some VIP asked me when I was Director General what we should do for this country. I said, just copy the health services of Indian Army, which has 200 hospitals and 6 super specialty hospitals, all taxpayers' money, all done very well, and we are so satisfied today. I hang my uniform from this hospital of Army Hospital, our Apex Hospital. I joined Gangaram Hospital. So I don't say that private healthcare is bad, but the answer to this is what other speakers were telling, and I fully agree about it, that you need a very good health service in this country. And I will be rather simple. I don't know, you have heard this story. There was a musician, a music director, Naushad, and science looks difficult because people have not understood science. So musician Naushad was not doing very well, and another musician was doing very well was O.P. Nair. And one day his cook of Naushad was singing the tune of O.P. Nair, and so he was very annoyed. He says, why you are singing my opponent's tune? He says, you make such a difficult tunes. That's why we don't sing your tune. So science has to be simple. So I'll be rather simple. Look, we have a very good referral system in the country. When I was uniform, a lot of people ask me how you have collected so many cases of rheumatoid arthritis, this, that, because of a very strong referral system, which does not have bias, a bias of commercial bias or bias of other. So we have this in 1991, to be precise, after about 10 years of in the army, I went for my super specialty, and that time many specialties were available because people thought cardiology has this investigation, gastroenterology has this. But if you really ask me, rheumatology had just autoantibodies. And as a physician, I always thought that autoantibodies are something like for pathologists, not for physicians like me. And I started doing many things which gave me little name, and we progressed the scientific world. That is, I thought maybe peeping in the joint will give me some answer. And in 2003, much before anywhere in the world, we started doing the musculoskeletal ultrasound. A lot of my colleagues used to laugh at me that there's nothing like musculoskeletal ultrasound, and now whole world is. So in 2003, in Army Hospital, we established the musculoskeletal ultrasound and also the medical arthroscopy program, both, and that gave a lot of nice things, and not now, it is, I'm talking about 2003. Treating arthritis was something like this. Even today, you'll not believe, even in very developed country, even in this country, in villages, treating arthritis was like this. Many drugs came, there's nothing wonder in the medical science. Science is always remains, science is not a wonder, science is more of a legitimacy. But this man, I always show this photograph because he's Indian, he's a third generation Indian, Mani, and Dr. Ravindra Mani from Charing Cross Hospital, London. And he also used these drugs, and we also used much, and that's why because of these three things, I had named that they had about 27 patients in 2002, and we have about 127 patients on biologics. That gave us, so three things we established now so much people know about cardiology. I'm very sure if I ask 10 questions to people, people will say so many things about cardiology. Unfortunately, the mobility, as I say, these people, they are not there in these conferences. They are not there in the parties to tell their stories. They vanish from society. If my wife is suffering from rheumatoid arthritis, she will just vanish from the scene. And that's why research is so poor. In last 20 years, it has seen about 6 Nobel Prize in clinical immunology and rheumatology, and that changed the world to, and this photograph I always show to the physicians, especially the family physicians, and this photograph is not from textbook of medicine, rheumatology. This is from textbook of medicine. And today, like you have studied neurology, the whole thing is like neurology only. What is the level of the lesion? The level of lesion in rheumatoid arthritis is synovium. So if a patient come to you, as you do in neurology, the first question you ask, what is the level of the lesion? Level of lesion in rheumatoid arthritis is synovium. So it's a synovial disease. It's a main onslaught is on synovium. Unlike these diseases where our ex-Prime Minister Atal Bihari Vajpayee had arthritis, which is osteoarthritis, the level of lesion is cartilage. Where in other arthritis, which is common in male, the level of lesion is tendon and ligaments, which we call as tendinopathy or enthesopathy. And in the gout, the level of lesion is fluid, so on and so forth. So it is something like when you talk about rheumatology, you must learn the science behind it, and especially family physicians, because these patients go to family physicians. And I can tell you, you know so well about first heart sound, second heart sound, rhonchi, crepitations. Unfortunately, 50,000 students in this country, 50,000 medical students, and rheumatology is not taught in the medical college. Even city of Delhi, there are hardly 2 or 3 DM qualified rheumatologists. So you can imagine the biggest issue of rheumatology. It's not taught at the MBBS level. I wish it is taught at the MBBS level. It's like any other science. You have various causes. You have various, whatever arthritis you have. A lot of people ask me, they were classified as connective tissue disorders. And tell me, where is connective tissue? You know, heart is here, the brain is here. Where is connective tissue? The connective tissue is ubiquitous. It is present all over. That's why you have a patient who loses hairs, who has oral ulcers, he has this, arthritis, pleural effusion, cardiac effusion, pericardial effusion. So a lot of people ask me, what type of disease is this here? What is the level of lesion? The level of lesion is connective tissue. And where is connective tissue? It is ubiquitous. It is present from head to toe. So if you have a patient who is multi-system disease and cannot be explained by infection, so you must see the autoimmunity as a cause for this. What is medicine as a science? It's a science of probability. That's why when you sit with a patient, they ask whether these diseases are curable. And as a good doctor, which you are not a businessman or you are not a statistician, that 2% will die and 4% will survive and 30% will. You are a doctor, you are a family doctor. You must learn how to communicate. I am very sure there must be a lecture in this, how to communicate with the patient. Soft skills are very important. What you discuss in hall is different. What you real practice in your clinic is different. So you have to talk to the people. Yes, a lot of people ask me, is these diseases curable? I said, yes. It's like treatment is available today, like hypertension and diabetes. It's a long-term treatment. If you take treatment, your complications are like you treat hypertension, because if you don't treat, you'll have a stroke. You will have myocardial infarction. Same thing, if you don't treat arthritis, then you will have complication of arthritis. So definitely today, these diseases are treatable. So I always write on my prescription, arthritis is treatable. How to approach? Like any other. If you have fever, you ask, kitne din se hai, kab se, how long you are suffering. Same is it a joint problem or it is not the joint problem, it is around the joint. So you call articular or periarticular. That is the first question you ask. Next question is it a pain is inflammatory or non-inflammatory? Something like, suppose you have an injury. That is a non-inflammatory pain. You have injury and you have, say, disc prolapse. That is not the inflammation. That's a mechanical thing which is happening. They are mechanical pain. They are different from a pain of inflammation, which I'll teach you how to differentiate between. So the second question you ask is it an inflammatory pain or is it a non-inflammatory pain? Then things become very simple, like any other MBBS doctor, which is like a science, whether you have one joint involved, many joints involved, or less than many joints involved. We call it monoarthritis oligoarthritis and polyarthritis. Cutoff is somewhere 4 to 5 joints. So one joint, 4 to 5, oligoarthritis and polyarthritis. And of course, acute, chronic, all those things which we know about it. But I'll tell you the physician's approach, how I practice after so many years. I don't practice as a rheumatologist. I practice as a MBBS doctor when I sit in the clinic. I ask first question, is the patient anemic? Yesterday I saw a patient, 6 gram hemoglobin, going around, referred to rheumatologist, coming all the way from Darbhanga. Anemia is the cause of the joint. So treat the anemia and anemia. Diabetes. Highest person in the defense services is defense secretary. One defense secretary in this city came to me, look, I have been diagnosed as rheumatoid arthritis in a premier institution in this country. And somebody told, like you show to Dr. Chaturvedi also. I asked only first question, are you diabetic? He said, yes, I am diabetic, but nobody asked me. He said, either this is diabetic chiroarthropathy, classical. So diabetes as a joint symptoms, because diabetes causes the problem of the blood vessels. Like because retinopathy you know very well, but joint symptoms you don't know. So they will have a lot of symptoms in the hand, and that is called as diabetic chiroarthropathy. Thyroid, so common, which you know about it. Of course, you should not forget about infections, viral, especially in this country. Dengue, a lot of people say, dengue, after dengue I am having this. Yes, the dengue and reactive arthritis, post-dengue arthritis, very well known. And this is a common practice. It goes in society. It doesn't go to even physician. It goes to the family physicians or a plain MBBS doctors. So you should know about asking 5 questions. Are you diabetic, thyroid, anemia, infection, viral infection? And another thing is any infection in the GI tract and urine infection. That is reactive arthritis. So people will come, sir, I had a diarrhea about 15-20 days back. Now I have arthritis. This is called as reactive arthritis. Few other diseases can depression. And I'm very sure if this crowd, generally doctors are very well known for depression. Depression is the #1 cause for joint pain. If you have not, so depression, especially in the terms of women. So another thing is, of course, the hypermobility syndrome. There was a home minister, his secretary used to come to me, tall fellow, and every time he will come to army hospital and he'll say, I have a joint pain. I said, everything is normal here, I can't diagnose you. One day he came in shorts and he was standing like, you know how the children stand. I don't know whether you have noticed, children always stand as a hyperextension of the knee joint. They will stand like this. I saw him, and that is a sign of hypermobility. So hypermobility syndrome, there are many other signs as a cause. It does not require treatment, requires probably reassurance. And of course, a lot of drugs. Another patient came to me, some VIP politician has a wife had a tuberculosis of abscess behind the breast. It was drained. There was abscess. It was drained. Turned out to be tubercular. Put on ATT. After that, she started deteriorating, and she came on stretcher. I still remember, very good-looking female, unkept, as if she has not slept for many days. He said, "Doctor, I just cannot." And nobody knows what is the diagnosis. I says, it's a drug-induced lupus. So if you have a patient, somebody has a joint symptom, the first thing you ask is he taking medicines? Because that is the easiest way to stop the medicine, and that will become better. So this is diabetic chiroarthropathy, which I was talking about, because hand mobility becomes less, and they have a stiffness, and the stiffness you always feel it is a rheumatoid arthritis. Thyroid, I was talking about. Leukemia, especially in the children. Somebody rang me up in the evening, Doctor Saab, I have a lot of joint pain, my servant is having. I said, I'll see you tomorrow. I'm a rheumatologist, I'm not a cardiologist. So I just work from 8 to 5, 8 to 8. He said, no, it's having a lot of pain. You must come. Lot of pain, young patient. I immediately went, do a peripheral smear, acute myeloid leukemia. That severe pain, so malignancy. This will skip the... So when somebody comes to me, beside all these questions I ask, I call it head to toe survey, which you call as general physical examination, which is very well written in the books. But I have to do in 5 minutes. I have 200 patients in front of me. So I start from hairs. Any problem, the hairs, eyes, nose, just go down. And that gives you a diagnosis sometime. Suddenly someone says, Doctor, everything is all right, but I have a skin issue here. The skin issue is psoriasis, so psoriatic arthritis. Arthralgia versus arthritis. Now, a lot of patients are referred to me that he has a arthritis. So learn from today to differentiate, and you know it, how to differentiate. Swelling is arthritis and no swelling is arthralgia. Of course, what the ultrasound has done, put an ultrasound probe on this, you might feel a swelling inside also. That is what we have, our work was. But for a crowd like this, arthralgia and arthritis decided by swelling, periarticular or articular. Now, what I did, I wrote an article in API that you just take a pen. In fact, I always carry that pen of red and blue. So somebody asked me, and I call it Ved's method of red and blue. Just, you don't need an MRI, you don't need a CT scan, you don't need ultrasound. Whenever there is a swelling, you mark as a red, as this has been done here. And if there is no swelling, you mark as a blue. And that gives you beautiful anatomical correlation, whether it's a joint issue or it is a ligament issue. And as an MBBS doctor, you have read about if sometimes swelling is in the whole finger, and the whole finger is because of the ligaments, which we call as Saucer's digits. And sometimes it is only in the joints, then you know it is in joints. Suppose the swelling is here, then it is in the tissue. So that gives you anatomical correlation immediately. And that is how these markings are done. Now, for this crowd, I was making these slides in the morning. It is age-wise, that's much easier. So, arthritis of young females. Now, it does not mean, but prototype. The main issue, if somebody has an arthritis of young female, that is rheumatoid arthritis. So you must learn that way. If a young female walks to you, probably it is like when I joined rheumatology, somebody told me, you must be treating journals only. I said, no, my 90% patients are young females. Autoimmunity is common in young females, while malignancy is common in the elderly population. So young patients, a female, arthritis, probably rheumatoid arthritis. So that is how it is. Arthritis of young males. A young male, 16, 17 years, studying in college, and he comes to you, the diagnosis is spondyloarthropathy. And let's forget about this word, just remember spinal arthritis. So somebody has a knee issue, somebody has a heel issue, somebody has a back problem, that is a spinal arthritis. If you understand these two messages, believe me, from today onwards, you'll be better than so many other doctors. Young females, rheumatoid arthritis. Young males, spinal arthritis or spondylo. It's a Greek word. It's like using a Sanskrit. So I use simple word, spinal arthritis. And arthritis of senior citizen, that is a osteoarthritis. And arthritis of children, simple, it's a juvenile arthritis. So it's a rheumatoid arthritis. Now, young females, next is hand joint arthritis. So somebody has a knee joint arthritis, at your level you don't diagnose, but at your level somebody is a hand joint arthritis, it's a rheumatoid arthritis. So young female, a hand joint arthritis, a symmetrical arthritis, both joints are involved. When I finish 25 minutes, kindly just tell me, I'll stop. So if both the joints are involved, so symmetrical arthritis, and of course is the morning stiffness, which I'm going to talk. So this is how the rheumatoid arthritis age-wise is diagnosed. This is how it used to be diagnosed when we were a student, and now it is diagnosed like this at an early stage. That is how the change has occurred by various investigation. This is arthritis of senior citizen. This is a photograph of our ex-Prime Minister, osteoarthritis, and it looks like this. And the level of lesion is cartilage. It is a disease which does not have a significant morning stiffness. The word is significant, and I'll describe what is significant. Arthritis of young males. Army is made of 1.2 million males. Before joining Gangaram, I was in Army hospital. So people ask me, how you have 8,000 ankylosing spondylitis patient, maximum in the world. Nobody has from single center. Not because of me, because I'm working in an organization which is a male-dominated 1.2 million army, and a very good referral system, and a very good primary care. It has been taught to the people how to diagnose it, because these are the people, they get stiffness in the morning, and there is a joint here in the undergarment, which I call it back pocket pain or gluteal pain. So this is covered by this, and actually there is a joint here which is called a sacroiliac joint, and that joint gets fluid inside once you take rest, and they will keep going to neurologist, somebody will operate them for a disc, they'll go to orthopedic surgeon. Actually, it's speaking, it's a spinal arthritis, and they can also have pain here, swelling here, and lower limb. So basically, rheumatoid arthritis, upper limb, spinal arthritis, lower limb. If you remember this, it is easier. If you don't treat, this is the story. And this is the difference which I was talking about between spinal arthritis and rheumatoid arthritis. Young female, young male, hand joints, it is the spinal joints and lower limb joints. It's a synovial pathology. Rheumatoid factor is positive. It is rheumatoid factor is negative. HLA-B27 is a gene. You know about so many things about gene. You need not to learn more than that. Just write HLA-B27. That is how it is. So HLA-B27 is positive. And if you are writing one investigation for this you write rheumatoid factor and anti-CCP. And for this you write X-ray of this joint, this. And this is called as X-ray of the sacroiliac joint. You know so well about writing X-ray lumbosacral spine. And moment you write it, you miss these joints. So from today, you write X-ray lumbosacral spine, X-ray of the SI joint. And SI joint is seen because SI joint cannot be seen in lumbosacral spine, so you have to write like this. And of course, juvenile arthritis. Periarticular. Now come to inflammatory. That is a very important question. Whether the pain is because of inflammation, and this inflammation is an immune inflammation, ladies and gentlemen. It is not a, when Dr. Raman, I'm really grateful for him that he called me. I really wanted to speak and I really wanted to teach this subject. It's from my heart. I'm doing for last 30 years. I was lucky that I was the first DM in rheumatology in this country. And since that time I'm teaching, and I always feel science is simple. Let's not make it complicated. If you have made it complicated, you have not understood it. That is how it has happened. Because a lot of people will say this had autoantibodies, that antibody. It's not. The gold standard test in rheumatology is not there. It's like blood sugar. Blood sugar is a gold standard test for diabetes. Your blood sugar, even a nurse can diagnose diabetes. You don't require a doctor to do that. In rheumatology, it's a clinical. The diagnosis still remain clinical. Not a single test is diagnostic. If you say rheumatoid factor is diagnostic, no. It's something like you diagnose chronic bronchitis. How you diagnose chronic bronchitis? 3 months, 3 years, cough, expectoration. It's a clinical diagnosis. So it's a clinical diagnosis. And it is the simplest to learn is a clinical. So you don't. Inflammatory versus non-inflammatory. That is probably the last 2-3 slides. You must learn that if a patient says, when I sleep in the
25
night.
minutes up, sir.
Okay. After 3-4 months, after in the night, I take rest for 3-4 hours, and the whole thing becomes stiff. That is the inflammation. That is the immune inflammation. Why? Because after the rest, what happens? The fluid accumulates in the joints, and that is the hallmark of immune inflammation. So we'll stop here, and to summarize the whole thing is that still the diagnosis is clinical. You must remember the diagnosis is, these are 2 slides. The clinical history is 80%. I think this is not seen here. Physical examination 10%, 5% is lab test. So you can imagine, and this is the last slide, that of course the clinical examination and sorry, I think this is here, that it's a strongly clinical discipline. It's like family medicine. And family medicine and rheumatology has to be come together because it is much easier. It can be practiced right into the periphery as a primary healthcare. Thank you, ladies and gentlemen. Thanks.